Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is actually an interesting and a rare occurrence of cervical superficial myofibroblastoma. So this is a case of 41-year-old female patient who's known case of breast carcinoma and presented with vaginal spotting and was found to have a cervical polyp. And this is the low power magnification of the cervical polyp. We have here the cervical mucosa, the unremarkable cervical mucosa, and this is what appears to be the increased cellularity part of the where the lesion really starts, and this is the Grenz zone. It's extremely important to remember that in this particular lesion, there is a Grenz zone between the lesion and the mucosa. So let's go on high power magnification to look at the lesion. This is a lesion that is composed of proliferation of spindled to stellate cells showing minimal pleomorphism. There is almost no mitotic activity encountered at all. What you might start seeing is some collagen fibers present here and there, scattered among the cells, and actually sometimes produced directly by the tumor cells and then scattered mast cells. Important clue to the diagnosis, and again the oval to spindle to some sort of stellate cells with the collagenous background. Sometimes you might encounter what looks like lipoblast, or a fatty component can also be encountered in some of the described cases. And here again, the appearance of the lesion: collagenous stroma, scattered cells with the stellate appearance and spindle cell appearance, and the collagen again here, some minimal pleomorphism, but definitely no necrosis and no mitotic activity. So the differential diagnosis really is that of stromal proliferation or stromal lesion, including a large number of differential diagnoses like cervical polyp. Could this be something that is leiomyomatous? Could this be spindle cell proliferation, for example, neuromatous, neurofibroma, other differential diagnoses that can be encountered in that location. And the first stain that was done was Desmin, and surprisingly, the tumor was strongly positive for Desmin immunohistochemistry. So remember, this is the normal mucosa, the Grenz zone, which is extremely important, and then the Desmin, and on higher power magnification, strong diffuse positivity for Desmin. So the first thing that would come to mind is this rhabdomyosarcoma. One important clue that is seen actually on the H&E and on the low power magnification is of the immune stain of Desmin is the Grenz zone. So if we're thinking of rhabdomyosarcoma, remember that rhabdomyosarcoma tends to grow directly underneath the surface epithelium, forming the cambium layer, which is not the case in our example. However, we have to confirm whether this is a rhabdomyosarcoma or not, because this is the single most important differential diagnosis in this condition, and myogenin and myod1 were both negative, so ruling out the diagnosis of rhabdomyosarcoma. Now, CD34 tends to show positivity in the tumor cells. In this example, it was kind of patchy, it wasn't diffuse, and ER is usually positive. We have the internal negative control of the endothelium. Smooth muscle actin is described to be positive in some of the cases. It was not in this case. P53 showed wild mosaic staining pattern. S100 and SOX10 were negative, ruling out a neuronal tumor. So the final diagnosis of this case is cervical superficial myofibroblastoma. This is a rare benign tumor of the lower female genital tract, mostly seen in the vulvovaginal area, rarely described in the cervix. What is really important tip is that the tumor is usually strongly positive for Desmin, but remember, once you see this positivity, you have to rule out rhabdomyosarcoma, and we have two clues. Number one, the green zone that is characteristic of this lesion, and number two, the negative staining for MyoD1 and myogenin, essentially ruling out rhabdomyosarcoma. I hope you find this tip useful in your daily practice. Thank you.